Okay, good morning. Hello, everyone. Thank you for attending today's webinar, Recent Developments in Employee Benefit Plans. Before we begin, we want to cover a few housekeeping items. If you have any questions during the webcast, you can submit them through the Q&A widget at the bottom of your screen. We will try to answer these during the webcast, but if a fuller answer is needed or we run out of time, it will be answered later via email. A copy of today's slide deck is available in the resource widget. We encourage you to download any resources or links that you might find useful. If your screen freezes during the presentation, you can select the F5 key to refresh your screen. You can find additional answers to some common technical issues located in the Help widget at the bottom of your screen. This webinar is CLE accredited in California and Illinois for 1 hour of general credit. Missouri is approved for 1.2 hours of general credit. New York, transitional and non-transitional for 1 hour of areas of professional practice, and Texas for 1 hour of general credit. This webinar is also approved for 1.0 hours of HCRI and SHRM credit. We award CLE based on attendance for the entire 60 minutes. Due to changes in jurisdictional requirements, you will notice that we are no longer using automated pop-up attendance checks. As required, we will display secret words in 2 multiple choice polls during the webinar. You will be required to select today's secret word from a multiple choice list. Please respond to these polls to demonstrate your continued engagement and earn your full CLE credit. We value your opinions and appreciate your participation in the course. All right, with that housekeeping out of the way, let's go ahead and get started. We've got a lot to cover, and hopefully we are able to get to it and leave some time for any questions. So the last few years have been really busy in terms of legislative and regulatory activity. The focus has really been on health and welfare plans, requirements like transparency, mental health parity, COVID-19 changes have been, sort of top of mind. There have been some impacts on retirement plans, but as we said, most of it has been focused on health and welfare plans, and that's where we'll focus the majority of this webinar. So in terms of legislation, the 2 sort of big pieces of legislation moving through Congress now, the infrastructure bill, which was signed, I believe, yesterday by President Biden, and the Build Back Better Acts, which is still going through the process of the reconciliation. There's benefit provisions in both of these. So the Build Back Better Act is the part of the Biden agenda that's going through the reconciliation process now. It's been the subject of some pretty heated negotiations among the Democratic caucus, and it faces uncertain prospects. So the current framework, as I'm describing it, is subject to change. The bipartisan infrastructure bill that was signed into law, also known as the BIF, is called formally the Infrastructure Investment and Jobs Act. It was passed by both the House and the Senate, and at the time I did these slides, Biden had not yet signed it, but he did yesterday, I believe. So looking at the Build Back Better Act, some key benefits provisions include the lowering of the ACA affordability threshold for purposes of the employer mandate on large employers to provide health insurance. Currently, that affordability threshold is about 9.5% of household income, and it's indexed. The Build Back Better Act would move that down to 8.5% of household income with no indexing. So this will impact your ACA compliance and reporting on your Form 1094 and 1095Cs. So something to keep in mind as you think about the pricing for your health insurance coverage if you're subject to the employer mandate. The Act would also expand marketplace subsidy eligibility, so it would extend premium tax credits to those above 400% of the poverty line and increase the subsidy amounts for those below that level. This means that if you're not currently offering or you don't offer in the future qualifying coverage and you're subject to the employer mandate, it increases your risk of incurring a B penalty. And the B penalty is imposed when you don't offer qualifying coverage and someone goes to the marketplace and gets a subsidy. So expanding the group of people who are eligible for a subsidy expands the potential group of employees who could go to the marketplace and cause you to incur a penalty if you're not offering qualifying coverage. It also provides subsidies to individuals in states that have not expanded Medicaid. So this would make that group eligible for the subsidy even if the employer offers affordable coverage. One key thing to note here, though, is that this subsidy will not trigger the B penalty if you offer qualifying coverage. They can still get a subsidy from the exchange, but it won't impact your potential penalties. The Build Back Better Act would also increase penalties for mental health parity violations. It would place a cap on aggregate individual retirement account and defined contribution account balances starting in the year 2029. That cap would be a $10 million maximum in all accounts for an individual, at which point distributions would become mandatory. Employer plans are required to report any balances to the IRS that are over $2.5 million. It would also eliminate Roth conversions for high income taxpayers. It possibly will include paid leave. That's been the subject of a lot of intense negotiations. The current framework indicates 4 weeks. Earlier proposals would mandate that employers provide a defined contribution plan of some sort to their employees. That's been eliminated from the current framework, but as we've been discussing, this is all subject to change as it moves through the reconciliation process. The infrastructure bill is generally focused on hard infrastructure, roads, bridges, etc., but it includes a couple of benefits-related pay-for items that are intended to reduce the cost of the program, raise revenue to help pay for the infrastructure bill. One of those was extending the pension smoothing that was first introduced in the American Rescue Plan Act, so that would impact defined benefit plan sponsors, give you additional time to make contributions and smooth out investment losses. It also delays a change to the anti-kickback statute for prescription drug rebates for Medicare Part D. And that really impacts only employers who sponsor sort of retiree medical plans, including EGWP plans. The delay in the deductions available to employers as caused by these changes would lower the cost of the bill. So that's why they were thrown in there. Finally, there's other legislation that's been around for a while, but there are amendments that may be coming due in the coming months and years that you need to keep an eye on. One of those changes came about through the Secure Act. The Secure Act made a number of retirement plan changes that are now going to be required to be reflected in your plan documents. One element of that was that it expanded and required eligibility for long-term part-time employees. So employees who work at least 500 hours in 3 consecutive plan years are required to be offered eligibility to contribute to a 401k plan. It doesn't change the requirements with respect to any employer contributions, but they just need to be offered the chance to fund their own retirement. It delayed required minimum distributions to age 72 from age 70 and a half. It increased the safe harbor for certain automatic contribution arrangements that have auto increase provisions built into them. The old safe harbor let you go up to 10% of income. This increases that to 15%. The Secure Act is also going to require an annual disclosure of lifetime income for defined contribution plan participants. So basically, employers will be required to indicate how much in lifetime income they can expect for their defined contribution plan account balances. It also limited the stretch payments that can come to beneficiaries after death, basically accelerating when you have to make required minimum distributions to individuals who are beneficiaries under a defined contribution plan. There were a lot of other changes that are not necessarily reflected in an individual employer's plan, such as expanding availability of pooled and multiple employer plans. If you are interested in participating in those programs, it became a little bit easier due to the Secure Act. Amendments to defined contribution plans and defined benefit plans as a result of the Secure Act are required by the end of the 2022 plan year. So next year will be key to getting that done. Another piece of recent legislation was the CARES Act, which was passed early in the pandemic last year. It allowed plans to make coronavirus distributions of up to $100,000 to qualified individuals who were impacted by the pandemic. Those coronavirus distributions are allowed to be recontributed to the plan if the plan allows, or recontributed to an individual IRA. The CARES Act temporarily waived the RMD requirement for 2020, and it also increased the loan limit during 2020 to the lesser of $100,000 or the participant's account balance. That was for loans that were initiated between March 27th, 2020 and September 22nd, 2020. It also gave relief for outstanding loan payments that were due from the period starting on March 27th, 2020 to December 31st, 2020. Those loan repayments are allowed to be delayed for up to 1 year. So to the extent you need to amend your plans to reflect any of these provisions of the CARES Act, again, you've got a 2022 plan amendment deadline to keep in mind as you head into next year. Finally, some recent legislation created some flexibility for flexible spending accounts that allowed carryover unused health and dependent care FSA amounts from 2020 into 2021. Those need to be reflected in the terms of your plan document if you allow this flexibility by the end of this year. So just a few weeks left if you need to amend any flexible spending accounts to reflect what you did for this recent change. Okay, we've come to the first secret word of the day. This first secret word is water. So please select the correct word from the selections below. Make your choice so that you can demonstrate that your attendance is valid for this CLE. I'll give you a few minutes to enter that information and then pass it on to my colleague, Amy. Again, the secret word is water. Okay, it looks like most folks have been able to enter that, so I will turn it over to Amy.
Good morning, everyone. Our next topic is transparency, which is primarily affecting group health plans as we move into 2022 and subsequent years after that. So transparency is coming up from two different sources. The transparency and coverage regulations were issued by the IRS, DOL, and HHS in November of 2020. These were expected. They'd been in the works for quite a while, so it wasn't a big surprise when they came out. And then a little over a month later, in December of 2020, the Consolidated Appropriations Act was passed. So obviously legislation versus regulation. And this included several transparency requirements for group health plans, some of which overlap with the transparency and coverage regulations and some of which are separate. So kind of the big question for several months was how do these coexist and what does that look like as we head into 2022? The agencies did issue guidance in FAQ Part 49 in August of this year, delaying some of their requirements and helping us figure out sort of what the new deadlines are going to be as we look ahead. But first, we're going to talk about the transparency and coverage regulations. These have two kind of key requirements. First is a set of individual disclosures with cost-sharing information, and the second is a set of public disclosures that are machine-readable files that people can access on the plan sponsor's website. These regulations apply to non-grandfathered group health plans and health insurance issuers offering non-grandfathered health insurance coverage. There are some plans that these regulations don't apply to, such as grandfathered group health plans and a couple of other types. So first, looking at the individual disclosure requirement of the transparency and coverage regulations, this is a requirement to provide cost-sharing information through an internet-based self-service tool or by paper or telephone. So this information must be based on actual negotiated rates for in-network items and services and allowed amounts for out-of-network providers. Plans must be able to provide a paper form upon request to participants. And the deadline for this, by January 1 of 2023, plans must have this information for at least 500 items and services. And the agencies, IRS, DOL, and HHS, are currently working on what that list, that 500 items and services is going to be. So it's not just any 500 items and services, it's a prescribed list. And then plans should have this available for the full range of items and services by January 1 of 2024. So we have a little bit of time for this one, but it is coming up in 2023. The next requirement is a set of public disclosures. So these must be available on a public website, and they must be machine readable files. So it's three different files, one for negotiated rates for in-network providers, one for historical allowed amounts and billed charges for out-of-network providers, and one for historic net prices for prescription drugs. So the FAQ Part 49 did delay this requirement. It originally was going to be January 1 of 2022 for all three files. With the FAQ Part 49 guidance, the in-network file and the out-of-network file are pushed to July 1 of 2022. And the prescription drug file is delayed indefinitely. So we have a little bit more time, but those are coming up in July. So then looking at the Consolidated Appropriations Act, this, again, it's legislation, not regulation. It includes several transparency requirements. Some overlap with the transparency and coverage individual disclosure requirement, some overlap with the public disclosure requirement, and then some are kind of standalone. Unlike the transparency and coverage regulations, these requirements apply to group health plans, including grandfathered group health plans. Again, there's a couple of other types of plans that they don't apply to, but they do apply to grandfathered group health plans as well as non-grandfathered group health plans. So these first two requirements under the Consolidated Appropriations Act are what we consider to overlap with the transparency and coverage individual disclosure requirement. The first is a requirement that plans provide an advanced explanation of benefits. So this means they must provide a description of plan coverage upon receipt from a good faith estimate from a participant's provider. This requirement has been delayed indefinitely by FAQ Part 49. So again, it's out there. It's important to keep in mind that it might become a requirement in the future, but for right now, it's delayed. Another individual disclosure type requirement is a price comparison tool. So group health plans must provide price comparison guidance by telephone and an online tool. It must be specific to plan year, geographic region, and participating employer. FAQ Part 49 delayed this to January 1 of 2023. And the idea behind the delay is to give them time to have more guidance to sort of merge this requirement with the transparency and coverage individual disclosure requirement so that plans have kind of a single set of requirements that they can comply with rather than having two sort of competing requirements that they need to accommodate. So again, we have a little bit more time. The price comparison tool is coming January 1 of 2023, but we are expecting more guidance on that. Next, we're looking at the Consolidated Appropriations Act requirement for public disclosures, requirement for machine readable files, which is a public disclosure, and it sort of mirrors the transparency and coverage public disclosure requirement. Again, it's a set of 3 machine readable files, one for negotiated rates for covered services with in-network providers, one for historical out-of-network allowed amounts and billed charges, and one for in-network negotiated rates and historical prices for all covered prescription drugs. Again, the first two, the in-network provider and out-of-network allowed amounts, are pushed to July 1 of 2022, and the prescription drug file, that requirement is being delayed indefinitely as we sort of wait for more guidance on that. Oops. Sorry. All right, so additional requirements under the Consolidated Appropriations Act, and these don't really overlap with the transparency and coverage regulation requirements. These are just sort of standalone transparency requirements in the CAA. First is a prohibition on gag clauses. This went into effect when the CAA was passed back on December 27th of 2020. So under this requirement, agreements with providers, networks, and TPAs cannot contain provisions that prohibit disclosures to plans of cost or quality information, and they cannot prohibit electronic access by plans to de-identified claims data for enrollees. So again, this went into effect almost a year ago, and it will continue to be in effect. Next is some new requirements for ID cards. So any physical or electronic ID card from a group health plan must disclose any deductible under the plan, any out-of-pocket maximum, and a telephone number and internet website that participants can use for customer assistance. That goes into effect on January 1 of 2022, so it's coming up here quickly. Another requirement is for a provider directory. Plans must provide a website database for in-network providers. This must be periodically verified by plans at least every 90 days. Again, this goes into effect January 1 of 2022, so coming right up. And finally is a requirement to provide a balanced billing notice, making sure participants are aware of their protections from certain surprise medical bills. The DOL has provided a model notice that's available on their website, and this requirement goes into effect on January 1 of 2022 as well. The CAA also included some provisions on mental health parity, and it added some new requirements for group health plans. So under the CAA, group health plans must provide a comparative analysis of non-qualitative treatment limits. These plans and group health plan insurance issuers must be able to make these analyses available to the IRS, DOL, and HHS, and to state authorities beginning on February 10th of 2021, which was 45 days after the Consolidated Appropriations Act was enacted. The agencies did release FAQ Part 45 with some additional guidance on April 1 of 2021, giving plans a little bit more information as to what all this entailed. So what must be provided in this comparative analysis of non-qualitative treatment limits? First, it's a description of the specific non-qualitative treatment limit, the plan terms, and the policies at issue. It must include identification of benefits to which the limit applies. It must include the factors, evidentiary standards, and other resources considered in determining the limit. It must include definitions of the factors, evidentiary standards, and other resources used. It must include an explanation of any variation of the limit, include qualifications of any experts used in the analysis, include the findings and results of the plan and the issuer upon completing the analysis, and include the date the analysis was completed, as well as the individuals involved. Again, this is all information that group health plans must provide only upon request. So if this information is requested and it's not provided, or it's not provided in its entirety, there's a 45-day corrective action period to provide any additional documents that are needed. If the non-compliance is not resolved at the end of that 45-day period, plans must provide a notice to all individuals enrolled in the plan, informing them of the non-compliance. So FAQ Part 49 did give some indication of what the agencies were going to be particularly focusing on as they start this process. It included 4 key topics. The first is a prior authorization requirements for in-network and out-of-network inpatient services, concurrent review for in-network and out-of-network inpatient and outpatient services, standards for provider admission to participate in a network, including reimbursement rates, and out-of-network reimbursement rates. So looking at the plan's methods for determining usual, customary, and reasonable charges. All right, our next topic is balanced billing and the No Surprise Billing Act. So before we really delve into this topic, I think it's helpful to have just a couple of definitions in mind. First, a balanced bill is the amount a provider charges that exceeds the allowed amount paid by a plan for an out-of-network service. And a surprise medical bill is a balanced bill for services a participant received when the participant was not able to choose services or providers. So a surprise medical bill is always going to be a certain type of balanced bill, but not every balanced bill is a surprise medical bill. So these protections that we're going to talk about apply to a certain subset of surprise medical bills. They do not apply to all balanced bills in general, just a certain subset of them. So the Consolidated Appropriations Act prohibits, beginning in 2022, 3 key categories of surprise medical bills. The first is emergency services rendered at an out-of-network facility by out-of-network providers. The second is out-of-network provider services at in-network facilities. And the third is air ambulance services. So again, any balanced bill that is not in one of these 3 categories, these protections do not apply to participants. Participants are still liable for those costs. The idea behind the prohibition on these certain types of surprise medical bills is that these are all circumstances in which the patient isn't necessarily the one making choices about care or what provider they are accessing. Again, in an emergency or an air ambulance situation, chances are that the participant is not really able to make those decisions. And in the case of an out-of-network provider at in-network facilities, the patient may not be aware, they may not be the ones making choices about their care. So it's all of these are situations where the patient may not be aware that they're incurring these substantial costs. There has been some guidance on surprise medical bills. So again, this was passed as part of the Consolidated Appropriations Act back in on December 27th of 2020. Since then, there were interim final rules passed or published in July of this year. It's called Part 1 of the interim final rules. Another set of final rules were passed in October of this year, and then proposed regulations on air ambulance services were issued in September of this year. So Part 1 talks a lot about participant cost sharing and how the costs are going to be determined. And Part 2 talks about the internal dispute resolution, which is how providers sort of negotiate the final amount that the provider should be paid for situations in which there was a surprise medical bill. So as a group health plan, what do you do when one of your participants receives one of these surprise medical bills that's prohibited under the Consolidated Appropriations Act? You have kind of 2 key responsibilities. One responsibility is to the participant to determine what their cost sharing amount is going to be. Under the regulations, there's what's called a qualifying payment amount, which is usually going to be what the cost sharing amount is going to be, but there's sort of a decision tree you have to follow for that, and then a specific calculation in determining what it is. And then any cost sharing amount that the participant is responsible for is going to be treated as in-network for purposes of deductible, copay, and coinsurance. And then, so kind of looking at what the participant owes is one step. The next step is looking at what the plan owes to the provider. So once the plan receives a claim from a provider for the what would be the balance bill, the plan can either send an initial payment to the provider or issue a notice of a denial of payment, and then the plan and the provider sort of enter into a negotiation period and an internal dispute resolution process to finalize what the amount is that the plan will pay to the provider. So what is the participant going to owe when there is one of these surprise medical bills? Generally, the cost sharing, as we talked about in the last slide, is going to be what's called the qualifying payment amount. There are a couple of other laws that may apply to set the amount of cost sharing. One is Section 115A of the Social Security Act. So that's the first source that you would look to see if there is a cost sharing amount set forth there. If not, then some states have laws that would have, if you're in a state that has a balanced billing law, you would look to that for the participant cost sharing amount. If neither of those apply, then you look to this qualifying payment amount. So this is a very specific calculation put forth in the regulations. For 2022, it is the median of the contracted in-network rates as determined by all of the plans of the sponsor, or all coverage offered by the health plan issuer in the same insurance market on January 31st, 2019, increased by the Consumer Price Index for all urban consumers. For 2023 and on, the qualifying payment amount is based on the previous year, adjusted by the Consumer Price Index for all urban consumers. So again, that's what we're that's the calculation we're looking at for determining the participant's cost share when they receive one of these surprise medical bills. So kind of stepping back and looking at this big picture, when a participant has received a surprise medical bill that's prohibited under the Consolidated Appropriations Act, the maximum cost that they're going to face is their cost sharing amount as determined under the qualifying payment amount calculation or under one of the other laws if one of those applies. The maximum cost to the plan is going to be the amount that it agrees to pay the provider, whether that's a separate agreement with the provider or an amount that's determined under the internal dispute resolution process. It's also important for plans and for participants to keep in mind that there is an option for participants to waive their surprise billing protections. This only comes up in one of the three categories of surprise medical bills. So again, we talked about emergency services, air ambulance services, and out-of-network providers at in-network facilities. The waiver is only an option in that third category for out-of-network providers at in-network facilities and only in non-emergency situations. The provider must give a certain notice to the participant of their option to waive. The notice must be given 72 hours in advance. It must include a good faith estimate of all items and services, all of the costs that the participant would face if they choose to waive their protections. And it also must include a list of in-network providers at the facility where the participant is receiving services. There's a specific term for ancillary providers. Any ancillary provider cannot ask for a waiver of these protections. An ancillary provider is defined as radiology, pathology, emergency, anesthesiology, diagnostic and neonatal services, as well as assistant surgeons, hospitalists, intensivists, and providers offering services when no other in-network provider is available. So any provider in those categories cannot ask for a waiver of surprise billing protections. If the provider asks for a waiver and the patient declines, the provider does have the right to refuse service. If the patient agrees, agrees to the waiver, it is the provider's responsibility to notify the plan that it does have a waiver. Again, remember that if the balance bill is not one of the Consolidated Appropriations Act prohibited surprise billing, if the balance bill does not come up in one of those specific circumstances, no waiver is required. The participant is still liable for the costs of any balance bill that they incur. So now we're going to look at the internal dispute resolution process. So this is how plans and providers sort of agree to an amount when there's been a surprise medical bill. This process can always be avoided if the plan and the provider simply agree to an amount before they enter into the dispute resolution process, or at any point during the dispute resolution process before there's been a final ruling. So there is, I think, a good incentive for providers and plans to come to an agreement before they even enter into this process and even before they finish the full dispute resolution process. This must be completed by what's called a certified IDR entity. This certification is, these requirements are sort of laid out in the CAA. The certification lasts for 5 years. It's unclear how many certified IDR entities are actually going to be available beginning in January 1 of 2022 when the law goes into effect. So that might be a sort of an initial hurdle that we face, is actually finding an IDR entity and seeing how many are available to plans and providers. So there's a very specific process with specific timelines for each step. So and I will say at the outset, for each of these steps, it's a certain number of days. Sometimes they are business days and sometimes they are calendar days. So it's important to keep in mind as you're actually going through this process that obviously business days and calendar days are different. So keep the distinction in mind. So once a plan receives an initial claim from a provider, the plan has 30 calendar days from the date the claim is received to provide either an initial payment or a notice of denial of payment. Once the plan provides that payment or notice of denial, either party can initiate what's called the open negotiation period. It must be initiated within 30 days from the date of the plan's offer or denial of payment. So if that 30 days expires, whatever the plan offered to pay the provider is considered final. If the negotiation period is initiated, it lasts for 30 business days, beginning on the date that of the initiation of the negotiation period. If no agreement between the plan and the provider is reached, then the formal internal dispute procedure must begin. It must start within 4 business days after the 31st business day after the initiation of the negotiation period. Okay, we're at our second secret word. Today's second secret word is green. So please select the correct word from the options below. Again, our secret word is green. I'll give you a few seconds to finish that. Again, today's second secret word is green. Okay, just a few more seconds. Again, our second secret word today is green. All right. Moving on. So our next steps for the internal dispute resolution process is to actually select the certified IDR entity. This must be done within 3 business days after the initiation of the IDR process. If the two parties, if the plan and the provider cannot come to an agreement on the IDR entity, the IRS, DOL, and HHS will make a decision for you. I believe they have until the 6th business day after the initiation of the IDR process. The parties must then submit offers to the certified entity within 10 business days after the selection. And then the certified IDR entity must issue a decision within 30 business days after the selection date. And finally is the payment. So that must be paid within 30 calendar days of the decision. Importantly, there is an IDR entity fee. So when both parties submit their offers, they both pay the fee, and then the winner of whichever offer is selected by the IDR entity, that entity, either the plan or the provider, does not have to pay the IDR entity fee. That amount is reimbursed to them. We'll go ahead. I think we're on to our next topic.
All right, thank you, Amy. Before I move on, I wanted to note there was a question relating to the CAA and surprise medical bills and whether they apply to individual insurance plans. And I feel free to jump in, Amy. I don't know the answer to that off the top of my head, but I would be very surprised if they did not, given the policy goals here. Unless you have something to add, Amy, that's just something we'll have to follow up on.
I agree.
All right, next topic that we're going to talk about is very timely. It's regarding wellness plans and vaccines. So a lot of employers have been interested since the introduction of the COVID-19 vaccines in incentivizing employees to get vaccinated. And one of the ways that folks have looked at doing that is through the use of a wellness program as part of their group health plan. The way that typically works is that the plan would impose surcharges or provide discounts on employer-provided health premiums to employees based on their vaccination status. On October 4th of this year, the tri-agencies DOL, HHS, and IRS provided some FAQ guidance on the use of wellness plans to provide vaccine incentives. These FAQs confirm that a wellness program implementing a vaccine incentive would be considered an activity-based health contingent wellness program for purposes of complying with the HIPAA non-discrimination rules that apply to wellness programs. So what are we talking about when we mention an activity-based health contingent wellness program? Under those regulations governing wellness programs for HIPAA purposes, one of these programs is something that requires a participant to satisfy a standard relating to a health status, but does not require the participant to achieve a particular health outcome. So in this case, the health status is the receipt of a vaccine, but no further outcome is required by satisfying that status. So for example, no requirement that the employee then from then on test negative for COVID-19. So rules relating to activity-based health contingent wellness programs. One rule is that you have to offer an opportunity to qualify at least once per year, an annual opportunity to get the incentive or to have the penalty waived. The reward cannot exceed 30% of the cost of coverage. So that would be the employee-only coverage cost for a program in which only the employees participate. And typically the wellness programs related to vaccines that I've seen have really been focused on employees, trying to keep employees safe, get them back in the office, et cetera. The plan has to offer a reasonable alternative standard if it is unreasonably difficult due to a medical condition or it is medically inadvisable for them to achieve the health status. The example given in the FAQs is requiring the employee to attest that to their compliance with the CDC's masking rules in order to have the reward available to that individual who cannot receive the vaccine due to medical issues. The plan must disclose the terms of the program and the availability of the alternative standard in any materials that you send out to describe the program. Typically, that might be your open enrollment materials, or in advance of open enrollment, descriptions going to employees, encouraging them to get vaccinated in order to get the incentives. Finally, the program must be reasonably designed to promote health or prevent disease. And obviously, the agencies feel that COVID-19 vaccines are designed for that purpose. The FAQs issued by the tri-agencies include some additional facts about the program that they found to be compliant and meet the standards for the HIPAA non-discrimination rules. Under the facts given by the agencies, the plan offers a toll-free hotline to answer vaccine questions and to assist with vaccine scheduling, to make it a little bit easier for employees who maybe have questions or have difficulty scheduling a vaccine to get that done through the plan. The FAQs notably did not discuss who pays for any mask that may be required for employees who are unable to achieve that vaccine status in order to get the wellness incentive. Presumably, the employer can offer to provide the mask as part of the reasonable alternative standard, be how I would look at that. The FAQs also address what may seem to be an obvious question, but obviously the agencies were receiving this question. Can a plan refuse to cover employees who do not receive a vaccine? The short answer is no, you can't do that. The longer answer is that HIPAA prohibits discrimination in health coverage that's available based on a health factor. The wellness rules are an exception to that prohibition. So you can have penalties or provide rewards to employees who participate in a compliant wellness program. You can't just have a flat refusal to provide coverage to employees who do not receive a vaccine. Other considerations that employers should keep in mind if they're interested in including vaccination status as part of their wellness program. For purposes of the Affordable Care Act, if you're an employer that's subject to the employer mandate that's required to offer affordable qualifying coverage, the affordability for purposes of the employer mandate assumes that no discount is earned and that the surcharge, if any, applies to an individual. So you can't take into account the reward when determining whether the coverage is affordable. The only exception to this rule is tobacco use, and the agencies agreed that they did not expand that exception in the case of COVID-19 vaccines. So employers will want to ensure, for example, that any surcharge you impose on employees who do not receive a COVID vaccine does not result in unaffordable coverage, because as we discussed earlier in the presentation, employees who then go out and get subsidized coverage on the exchange can trigger ACA penalties on the employer. So a quick reminder on the EEOC, which enforces the ADA and the Genetic Information Non-Discrimination Act. Their view on whether these wellness programs comply with these rules is still a mystery. There was a long saga over a number of years where they tried to publish some regulation. Those regulations ended up being withdrawn. They've indicated that they plan to issue new regulations, but they haven't issued any COVID-specific guidance relating to wellness programs and vaccines. So just as we're sort of in this limbo period with the EEOC, I recommend that employers continue to comply with the HIPAA rules and implement their wellness program as part of an employee benefit plan, because there is an exception under the ADA for programs that are implemented as part of an employee benefit plan. And there have been some circuit courts that have ruled in favor of employers who have been challenged by the EEOC with respect to their wellness programs falling within that exception. Finally, the FAQs came out and addressed a question that may have been on employers' minds. Are the COVID-19 vaccines considered preventive care? Preventive care under the ACA is required to be covered by plans without any cost-sharing requirements. And the agencies specifically added the added COVID-19 vaccines to the list of preventive services. And they applied that to any future expansion of eligibility for current vaccines or future vaccines that are authorized in the United States. All of those are considered preventive services that need to be covered by a plan without any cost sharing. So as I mentioned, it has been, go ahead.
No, I'm sorry, go ahead.
Yeah, as I mentioned, it has been a busy year, so there's been a lot of additional guidance that Amy's going to walk you through that's come out this year.
All right, thank you, Mike. So now just touching briefly on a few other some other guidance we've had come out this year. EBSA Disaster Relief Notice 2021-01 came out this year. This is an expansion or sort of a clarification of EBSA Disaster Relief Notice 2020-01 that came out in 2020. So the 2020 notice, as a reminder, it delayed deadlines for participants and plans until the end of the COVID-19 outbreak period for HIPAA special enrollment, COBRA election, and COBRA payment. Deadlines to submit claims, deadlines to appeal adverse benefit determinations, and deadlines to file external appeals. So again, the 2020 notice delayed all of those deadlines until the end of the COVID-19 outbreak period, which was defined as 60 days after the end of the COVID-19 national emergency. The 2021 notice issued this year clarified that these deadlines are extended until the earlier of 1 year from the original deadline or the end of the outbreak period. So if we're looking at the 1 year from the original deadline for plans, it's really important to be monitoring when these deadlines are coming up for your participants, keeping in mind that they're going to be different for, whenever the deadline was applicable to that participant, then the extended deadline is going to be different for each participant. So it puts a little bit more of a burden on plans to make sure they're staying up to date with all of their participants and their applicable deadlines. But again, it's 1 year from the original deadline or the end of the COVID-19 outbreak period, whichever is earlier. IRS Notice 2021-15 clarified some of the relief available under the Consolidated Appropriations Act. This is primarily relief for FSA plans. So it increases FSA carryover amounts for the 2021 and 2022 plan years. It extends the period for incurring FSA claims for 2020 and 2021. It allows post-termination reimbursements from health FSAs during the 2021 and 2020 plan years. It allows a special claims period and carryover rule for dependent care assistance programs when a dependent ages out during the COVID-19 health emergency. It also allows a mid-year election change in the 2021 plan year for FSAs, as well as for medical, dental, and vision plan coverage. Of course, all of these options are simply that they're optional for plans. There's no requirement that plans offer this relief for their participants, but if plans want to allow this relief, they can do so with this guidance. Then we have the COBRA Subsidy. This was part of the American Rescue Plan Act of 2021, passed on March 11th of this year. It was a 100% COBRA premium subsidy available from April 1st to September 30th of this year. To be eligible for the subsidy, a qualified beneficiary must first be eligible for COBRA due to either an involuntary termination of employment or because of a reduction in hours. That participant or qualified beneficiary must then actually elect COBRA coverage in order to receive the benefit. So looking a little bit more at how this works, each assistance eligible individual, so anyone who meets those requirements, is deemed to have satisfied the requirement to pay the premium from up to for as long as April 1st through September 30th. Those who were eligible and elected and are currently receiving COBRA coverage prior to April 1st, 2021 would also have their premiums waived during the subsidy period. Those who previously dropped or declined COBRA coverage were then offered a new election window during the subsidy period to receive the subsidized COBRA coverage. The subsidy remained in place only as long as the individual is eligible for COBRA. So if they were eligible beginning April 1, but it expired for them in July, then the subsidy expired in July. The DOL did issue cybersecurity best practices for plans and fiduciaries. These came out in sort of three sets of tips and best practices. So one is tips for hiring an online service provider. One is a set of cybersecurity program best practices. And one is online security tips. Some people have interpreted these to apply only to retirement plans, but there has been some suggestion that they apply to both retirement and health and welfare plans. So I think it's a good idea to take a look at your processes for both retirement and welfare plans and make sure you're complying in both regards. And just a friendly reminder, the IRS published Notice 2021-61 a couple of weeks ago, announcing the 2022 contribution limits. So the limit for elective deferrals under 402G1 for 2022 is $20,500. The annual compensation limit under 401A17 is $305,000. The definition for highly compensated employee under 414Q1B is $135,000, and the catch-up contribution limit under 414B2B1 is $6,500. And with that, I think we are ready for questions. I did want to go back briefly. The question about whether the requirements apply to individual insurance plans. If that question is about self-insured health plans, I would just note that there are some special options available for self-insured plans. For example, you could choose to opt into any applicable state balance billing limits. And there are some tweaks to the model notice that you would need to make for that.
Thanks, Amy. Yeah, I know there's a lot to unpack here and a lot of guidance. So I'll give folks just a couple of minutes here if they have any questions to enter them into the Q&A widget on your browser window so that we can address any questions that folks have relating to the program. I don't know, Amy, if you've seen anything come in, but I haven't seen any additional questions roll in yet.
No, I don't see any others at this point.
Okay. Well, one thing to keep in mind, it's been sort of a lot of discussion this year about vaccine mandates and vaccine requirements. And I know this OSHA rule is coming out, and folks may want to consider if they're subject to that OSHA requirement. To the extent you can, use your wellness program to help encourage folks to get the vaccine, that might reduce some of the burdens that you're facing if that OSHA requirement ends up applying to you. So that's something to keep in mind as we move forward with that process that, as it winds its way through the courts. So somebody has asked who to reach out to if there are questions related to CEUs. I'm not sure what that is. Amy, do you know what that is?
Not ringing a bell to me, but here, our next slide actually includes our contact information, our email addresses. Our contact information is on the Thompson Coburn website, and you're more than welcome to reach out to either one of us, and we'd be happy to find a time to chat if we can answer your questions.
All right. Thanks, Amy. I think we are at the top of the hour, so I want to thank everybody for participating in our webinar. Please complete and submit the survey that we'll display at the conclusion of the webinar. Thanks and have a great day.
Thank you.